Immune tolerance is when the immune system does not mount an immune response to antigens it recognises as self. However, lack or dysfunction of immune tolerance can be detrimental in settings such as allogeneic transplantation and autoimmune disease, where antigens deemed as non-self are attacked by immune cells. What if there was a way to induce tolerance in these patients so antigens are instead recognised as self? There are 3 broad applications where this could be advantageous. We will focus on allogeneic transplantations. Kidney transplantation is a life-saving procedure for patients with end-stage kidney failure that is caused by a number of conditions. The greater the degree of HLA matching between the donor and recipient reduces the risk of the recipient's immune cells from recognising the donor cells as non-self, lowering the risk of organ rejection. However, even in a 6 out of 6 HLA match, kidney transplant recipients still must take lifelong immunosuppressants to prevent rejection, which itself has many drawbacks that can adversely affect transplant outcome. Development of the immune response begins with recognition of HLA by T cells. T cells differentiate into effector cells. Effector T cells, derived from the host, can injure the transplanted kidney, a process called acute rejection, leading to graft failure. Reprogramming a transplant recipient's immune system to durably tolerate the kidney could circumvent these drawbacks. FCR001 is an investigational cell therapy that aims to facilitate allogeneic tolerance by creating a dual immune system in the transplant recipient. 3 weeks prior to the kidney transplant, mobilized stem cells and immune cells are collected from the peripheral blood of the kidney donor. Talaris processes hematopoietic stem cells, facilitating cells and alpha-beta T cells from the collected peripheral blood, which make up the FCR001 product that will be infused into the kidney transplant recipient. 4 days prior to the kidney transplant, the kidney recipient undergoes non-myeloablative conditioning to make space in the bone marrow for the engraftment of kidney donor HSCs. The recipient receives the donor kidney on day 0. 1 day following the kidney transplant, the FCR001 is infused into the kidney recipient. Facilitating cells are believed to enhance the homing and migration of donor HSCs to the non-myeloablated bone marrow, where they engraft next to the recipient cells. Donor and recipient HSCs mature into mutually tolerated functional immune cells. Donor facilitating cells, along with a specific number of alpha-beta T cells, may mitigate the risk of graft versus host disease. Donor and recipient immune cells are released into the peripheral blood and travel to the kidney. This durable chimerism means the donated kidney is recognised as self, irrespective of the degree of HLA match between donor and recipient. This reprogramming of tolerance lowers risk of immune-mediated rejection. This can lead to discontinuation of immunosuppressants and avoidance of debilitating treatment side effects. FCR001 has several potential clinical applications for induced tolerance through reprogramming, restoring, and replacing in allogeneic transplantations, autoimmune disease, and blood disorders.